Respected Chairperson, ladies and gentlemen, my dear friends. The topic for the next 15 minutes I am going to discuss about is non-HDL cholesterol. I will be dealing with some of the questions that has been asked with regard to triglyceride and cardiovascular events. Well, I cannot claim that I will be able to answer the questions. Maybe I will be generating more questions rather than answering some of these questions. Because as things stand today, it is definitely a very important question which I don't think anybody knows an answer. So definitely there is no point in my trying to answer those questions. Well, we know that statins have not eliminated heart attacks. You can see the yellow bars are the events that occur in spite of statins, and it is much higher than the red bars, which are the events that are prevented by statins. In diabetes, the story is not different. In HPS trial, for example, with 40 milligrams simvastatin, you can see that there is 22% risk reduction, which means 78% of events occurred in spite of statins. The same is true with primary prophylaxis in cards with 10 milligram of athrostatin. There was 32% risk reduction and 63% of patients developed an event in spite of statins. Well, this 22% and 32% are quite significant. If you look at statistically, the number of zeros before one will be quite immense. So they are statistically significant, no doubt about that. But from a clinician's point of view, possibly it is not adequate. We want further reduction in the event rate. Well, if you look at this graph again, you can see that the vast majority of people who develop a myocardial infarction has an LDL of less than 130. Which many of us will not treat. Of course, now with the new guidelines, many of us do treat. But in general, 130 is LDL, not cholesterol, is the level which most of us do not treat. And 77% of patients with a myocardial infarction has these levels. So LDL definitely is not the end of the story. LDL and statins possibly constitute the tip of the iceberg, which is about 35%. And the rest 65% are constituted by so many known and unknown things. The known things include low HDL, high triglyceride, remnants, and there are so many unknown things. Smoking, obesity, hypertension, genetics, etc., etc., etc. Now when you come to LDL again, we talk only about the quantity of LDL. Whereas we know that it is not the quantity alone that is important. The size, for example, is very important. You know it is a small, dense LDL which creates more problem. And now you know actually it is not the size that creates the problem, it is the LDL particle number. As the LDL becomes smaller in size, there are more LDL particles for the same LDL. Like for example, consider here, two patients with 100 milligram per deciliter of LDL, same LDL. On this side we have these patients with large buoyant LDL, and so naturally the LDL is large and so the particle number is less. On the other side, we have a diabetic or maybe an Indian and who has small LDL particles, and you can see that the particle number is much higher, more than 70%. Now if you consider this graph again, on the x-axis is the risk factors for metabolic syndrome. As you go to the right, the number of risk factors for metabolic syndrome increases. The yellow bar is LDL concentration, and you can see that the LDL does not change. As you become more and more metabolic syndrome, the LDL does not change. But the blue or the green graph is the LDL particle number, and you can see that it is rising immensely as more and more risk factors for metabolic syndrome are added. So the particle number is probably very important. So what is the relation between LDL particle number and non-HDL cholesterol? Well, I'll come to that later, but for the time being, just remember that LDL particle numbers are important, number one, and number two, there is a relationship between LDL particle number and non-HDL cholesterol. Let us come to some basics of lipoprotein particles. You can see most of the time you classify or characterize lipoprotein particles depending on their size. And you have the biggest lipoprotein particle, which is the chylomicron, and at the other extreme the smallest, which is HDL2 or HDL3. Now when you do a biopsy of an atherosclerotic plaques, these are the lipoproteins that you see in the plaque. There is the IDL, there is the LDLR or the real LDL, and the lipoprotein A and VLDL remnants. Now when you measure LDL in a lab, the measurement is usually depending on the size. So when you measure LDL, actually these three are measured. Not only the LDL, real LDL, but IDL and lipoprotein A are also measured. So when you say the LDL is 140, actually it includes all the three in the vast majority of laboratories. And you know lipoprotein A has totally different prognostic treatment, everything is different because lipoprotein A does not respond to statin. Lipoprotein A is purely genetically determined. So it is a sort of heterogeneous group, even though say it is LDL. More importantly, there is another particle there, the VLDL remnant, which is also pro-atherogenic but is not counted in the LDL as you measure in the laboratories. So, if you want to measure atherogenic particles, you should also measure the triglyceride-less proteins, which includes VLDL, VLDL remnants, and IDL or intermediate density lipoproteins, in addition to the well-known cholesterol-rich proteins, LDL, and more especially the small dense LDL particle, which can be done either by measuring apolipoprotein B or by measuring non-HDL cholesterol. So, to make a long story short, you can divide the lipoprotein classes into non-HDL, which is pro-atherogenic, and HDL, which is anti-atherogenic. Now, non-HDL cholesterol, is nothing but total cholesterol minus HDL cholesterol. With the result that if you want to reduce non-HDL cholesterol, there are two options. One is increase the HDL cholesterol, and two is reduce triglyceride and triglyceride-rich lipoproteins like VLDL. Let us start with HDL. Now this is the Treat to New Targets trial with 80 mg of atherostat, and you can see that the LDL has already crashed to less than 70 mg per deciliter. Even in this group of patients, you can see the x-axis is HDL concentration. You can see that the HDL level comes down, the event rate goes up. So even at the level of less than 70 mg of LDL, HDL is a marker of coronary event rates. But we have another trial here, the Jupiter trial, where again you can see this is the placebo arm where the LDL was much higher, and you can see that as the HDL comes down, the bars become bigger, the event rate goes up. But when you give 20 mg of rosuvastatin and bring LDL down to rock bottom levels of 50 mg per deciliter, you can see that HDL no more is important. It is a straight line. The HDL do not anymore predict coronary artery disease if your LDL is in the 50s. So that is what Jupiter trial tells us. Now HDL has anti-atherogenic property through many known and unknown factors, including reverse cholesterol transport. But what I want to bring your attention here to is with regard to LDL particle number, which I have already described. You can see that again HDL is in the x-axis. You can see that the HDL comes down, the LDL particles become small, dense, and the LDL particle number goes up. So as the HDL is low, LDL may not change, but the LDL particle number goes up. Now when you plot with non-HDL, the story is the same. LDL particle number increases, LDL becomes smaller. So HDL also determines what is the type of LDL that is present in that patient. The story with triglyceride is absolutely same. As the triglyceride level increases, the LDL becomes small. As the triglyceride level increases, there is no change in the LDL cholesterol, but there is a sharp rise in the LDL particle number. And you can see here, this graph was shown once, but I will describe it a little more. See, when the triglyceride level is less than 100, not 150 or 130 or 200, less than 100, you can see that the rectangular part is much higher, and the rectangle is pattern A, which means large buoyant LDL. Now as you cross 100, when the LDL becomes more than 100, you can see the curves cross each other, and the larger variety is the triangle, and the triangle is pattern B, which is small dense LDL particle. So triglycerides do tell us whether the patient is having small dense LDL or large buoyant LDL. With the result that now that we do not have any standardized method of measuring the size of an LDL, we have only reports saying LDL is 100. We don't know how much is small dense LDL and how much is large buoyant LDL. Maybe an easy way is to measure the triglyceride. If it is more than 175, or maybe even better, get the ratio of triglyceride to HDL, and if it is more than 3.5, it is probably a good indicator that your LDL is very malignant and dangerous. Even if it is 80 or 90, that is not a good story because it contains more LDL particle numbers. Now if you look at meta-analysis of all studies, you see that triglycerides do increase mortality. There is no doubt about that. There is an association between triglyceride and cardiovascular mortality. But this again is triglyceride and cardiovascular mortality. You can see a straight line there, which means as the triglyceride level goes up, coronary artery disease mortality also increases. Now we adjust for various factors, adjust for the HDL level, adjust for the small dense LDL, adjust for the LDL particle number, and then you see that the line has become horizontal, which means triglyceride no more predicts coronary artery disease, which tells you in fact that the result why triglyceride is dangerous is maybe because of its effect on HDL and LDL. Whereas you look at LDL, HDL, it doesn't matter. Even if you adjust for all factors, the LDL line is a steep line, which means HDL determines coronary artery disease. The story is the same for non-HDL. You adjust for everything, there is no difference. Non-HDL still predicts coronary artery disease. However, despite all these epidemiological and observational data, when you come to treatment, it is a long story of disappointment after disappointment. HDL therapeutics, interventional trials using HDL, whether it is hormone replacement therapy, whether it is CETP inhibitors, niacin, all have fallen flat. No advantage whatsoever as far as cardiovascular event reduction is concerned. Maybe it is because HDL is a very complex molecule. The HDL that we are increasing is not the right HDL. Maybe, as you can again see here, the large number of complex array of proteins associated with HDL. So HDL is a molecule which is still very complex and we do not know much about. Triglyceride lowering therapies, equally disappointing as far as the cardiologist is concerned. And after the ACCORD trial, the FDA has said that there should be a label saying that fenofibric acid may not lower a patient's risk of having a heart attack or stroke. So that is how things stand today. And the confusion was confounded by these new guidelines which has been mentioned earlier, the American College of Cardiology guidelines. The most important point with respect to these guidelines is that they looked only at randomized control trials. They did not look at observational data, they did not look at epidemiological data, only randomized control trials. And they tried to answer three questions. Number one, what is the LDL cholesterol or non-HDL cholesterol goals for secondary prevention? Number two, what are the same goals for primary prevention? And number three, what is the effect of specific cholesterol modifying drugs? That is all. Unfortunately, the answer to the first two questions was a big no. There is no evidence from randomized control trials that either LDL cholesterol or non-HDL cholesterol goals are required for secondary prevention. And unfortunately, the answer for third question was again, other than statin, no other drug showed any benefit whatsoever. So, there is no evidence whether LDL cholesterol or non-HDL cholesterol can be used in either primary or secondary prevention. Keeping fully in mind the fact there are lots and lots of observational studies, there are lots and lots of epidemiological data, there are even animal studies linking non-HDL with atherosclerosis. But unfortunately, there are no randomized control trials comparing one group to another with specific LDL cholesterol or non-HDL cholesterol goals. The non-statin cholesterol lowering drugs is again the same story. You have only very few trials in the statin era. Pre-statin trials you don't consider because now you know statins are important. There has been unable to demonstrate any further reduction, and so no support to use the use of non-statin drugs also. However, all the other guidelines, including the American Endocrinology guidelines or the NICE, National Institute of Clinical Excellence, or the JBS, Joint British Society, all other guidelines say, even after achieving LDL, if you are non-HDL high, you should use non-statin drugs. So why this confusion? What is the problem? Because in spite of all the epidemiological data, you don't have clinical trials. I think there are three possibilities. Possibility number one is that you have to understand the difference between a risk factor and a risk marker. A risk factor produces the disease, whereas a risk marker is not causative. It is like the sale of televisions and computers increase the incidence of coronary artery disease. Not because televisions and computers increase coronary artery disease, but increasing sale of these gadgets is a marker of the changing lifestyle. So when you reduce the risk factor, it reduces the disease, but banning televisions and computers are not going to change the coronary artery disease incidence rate because it is a risk marker. So is HDL cholesterol a risk marker? Non-HDL cholesterol a risk marker? In which case there is no point in trying to reduce non-HDL at all. In fact, as the Jupiter trial showed, what you should do is to aggressively bring down LDL if the non-HDL cholesterol is high. So that is possibility number one. Well, we do not know. Possibility number two is again equally important. Is it that we really do not yet know at what level of HDL and at what level of triglyceride we should treat? Because most of these trials which have failed, if you do subgroup analysis, you find that in those groups with a high triglyceride and a low HDL, there was benefit. Like for example, this is the field trial. You take patients with a triglyceride above 204, 23% risk reduction, a p-value significant, 0.01. You take patients with a triglyceride more than 204 and low HDL, 27% risk reduction, p-value 0.005. This is ACCORD. Again, you take patients with triglyceride more than 204, HDL less than 34, 31% risk reduction, p-value again statistically significant. So is it, and again large, all trials, hypertriglyceridemic trials, if you look at patients with a high triglyceride, there is benefit. So is it the answer? Is it that we really do not know what is the level of HDL or what is the level of triglyceride that we should treat? Maybe you should have further refine and say you should have an HDL from 25 to 30 or triglyceride from 100 to 80, something like that. Maybe we still do not know the answer to that question. And the last possibility, which to me personally is probably the right possibility, is that we have not found the right way or the right drug to reduce non-HDL cholesterol. Maybe we are not increasing the right type of HDL, whether it is CETP inhibitor or niacin. We are not possibly increasing the right type of HDL. Maybe by using fenofibrate, you are not reducing the triglyceride the right way. You may be reducing it, as Mahatma Gandhi said, maybe the goal alone is not important. How you get there is also important. The way you treat is also important. So to me, I think this is most possibly this is the answer. Why all these trials have fallen flat? Because we are not doing the right thing. Till statins came, for example, none of the other dyslipidemic drugs actually reduced mortality because they were reducing cholesterol through wrong ways. So that leaves me with the final question. Will saroglitazar fill the gap? Because saroglitazar is a unique molecule with a unique action. So will it reduce non-HDL triglyceride and also reduce cardiovascular event rate? It is only 18 months old. It is an infant. So we still cannot say whether it will reduce coronary artery disease also. But this, I think, is the final multi-million-dollar question which is hanging in the air. Will saroglitazar reduce non-HDL and also reduce vascular events? We will have to wait a few more years till the cardiac data comes up. Thank you very much.
Very good presentation.